Coming to question 8 of previous year NEET questions 2025. So this question we'll read from the last line. Which of the following is not used for initial management? So you have to find out the disease and think about what treatment is to be given and not to be given. Remember the question, what is not to be used? During stress we often get confused with yes or no questions. Okay, please note the word which is not to be used here. A 21 years old male with known type 1 diabetes mellitus presents with blood glucose of 700 milligrams per deciliter. Sodium was 128 milliequivalents per liter. Chloride was 88 milliequivalents per liter. The patient was severely dehydrated. I think the diagnosis is more or less obvious. This looks like a diabetic ketoacidosis. So to say diabetic ketoacidosis, there should be 3 criteria. The name itself says diabetic ketoacidosis. So diabetes means sugar has to be high. The latest criteria is sugar has to be more than 250 milligrams per deciliter to say it is high. There should be ketosis, which means the blood ketone bodies are commonly used as acetone has to be high. How high? It is more than 3 milligrams per deciliter. It may not be important, but just remember the value if you are able to. Next is acidosis. Decay is one cause of metabolic acidosis. What type of metabolic acidosis? It is high anion gap metabolic acidosis. Okay, in NEET 2025, some 3 questions had come on acid-base balance alone. Metabolic acidosis. When do you say acidosis? Bicarb is less than 22 milliequivalents per liter. Only and pH is less than 7.35. If this criteria is there, we tell it as metabolic acidosis. Metabolic acidosis may be high anion gap metabolic acidosis or normal anion gap metabolic acidosis. There are 4 causes of high anion gap metabolic acidosis. There's a mnemonic mud piles, but if you remember Hackman, first and the most important cause is diabetic ketoacidosis. Then we have lactic acidosis. That is, some components are getting accumulated in the blood. In DKA, acetone gets accumulated. In lactic acidosis, lactate gets accumulated. And in CKD or uremic acidosis, again few acids get accumulated in the body, and there are some poisons like methanol poison, ethylene glycol poisoning. These are some acids get added onto the body. And we have normal anion gap metabolic acidosis. Usually there is one disease, renal tubular acidosis. If you remember this one disease, it is enough. And the second one is diarrhea. Any cause of GI loss causes normal anion gap metabolic acidosis. Because GI secretion is basically bicarbonate. It is a base. When bicarbonate is lost, it leads to acidosis. What type of acidosis? Normal anion gap metabolic acidosis. Okay. If we have to go to the next step, how is anion gap calculated? It is sodium minus of chloride minus bicarbonate. That is measured cations minus measured anions. I am not discussing the entire basics, but if you are able to remember, it is well and good. The normal value is about 10 to 12. If it is more than 12, it is called high anion gap metabolic acidosis. So in DKA, to say acidosis, actually bicarbonate is less than 22, but definition say in DKA less than 18 is enough to make a diagnosis. Okay, so DKA is one condition causing high anion gap metabolic acidosis. So this patient is having sugar of 700. He is severely dehydrated. They didn't give any mention about the ketones or acidosis, but this probably has to be DKA because there are only 2 hyperglycemic emergencies. One is DKA, another one is HHS. The previous term of HHS was HONK, hyperosmotic non-ketotic coma. Now it is called as hyperglycemic hyperosmolar state. Hyperglycemic hyperosmolar state. The treatment is basically the same. When sugar is high, we are going to reduce sugars, we have to increase hydration. What is the basic difference is DKA is an absolute insulin deficiency. DKA is an absolute insulin deficiency. When insulin is totally absent from the body, there will be acid formation or acidosis. Acidosis is more dangerous than just a hyperglycemia. In HHS, there is insulin deficiency, but it is a relative insulin deficiency. Some amount of insulin is present, so the acid formation does not occur. Even if you don't remember this one, both are treated in the same way. So how will you treat DKA? Because the question is what you will not do in DKA, right? So remember this order. DKA is always treated by fluids, potassium, and insulin. So fluids has to be rushed in DKA. We are not discussing the actual fluid management, the dose and all, but remember, if one question comes, what is the important treatment in DKA? It is fluids and fluids. It is not insulin, it is fluids. The second step is potassium. Why potassium? Because insulin is a hormone. Remember, there are two in insulin. On giving insulin, glucose reduces, potassium also reduces. These two substances enter into the cells. So we are giving insulin to reduce sugars in hyperglycemia or DKA. As a side effect, potassium also reduces. So before giving insulin, we have to give potassium. Now what fluid you are going to give? So fluids are of two types. Again, it is reasonable discussing fluids a little bit because 2 to 3 questions came on fluids also in the last 2025 NEET. We have colloids and crystalloids. Crystalloids are the common fluids which we see in our ward during our residency, like the NS normal saline, Ringer's lactate, 3% saline, isolate M, isolate P, isolate G, and 5% dextrose, DNS, dextrose with normal saline, half normal saline, dextrose with half normal saline. So all these are colloids, crystalloids. Colloids are example albumin and hemosil. Crystalloids are very, very important in medicine because they are commonly used. So even if you don't remember colloids, remember crystalloids. Crystalloids are the fluids which are to be given in DKA. Okay, we'll continue with the question. So which is not used for initial management? 0.9% saline. In the last question we discussed 0.9% saline is the commonest normal saline which we use in the ward. If you remember the value, it has 154 milliequivalents of sodium and it has 154 milliequivalents of chloride. Even though it is called normal saline, it is not normal because the normal sodium value in our blood is 136 to 146 milliequivalents per liter. The sodium value of normal saline is high. The normal chloride in our body is 96 to 106 milliequivalents per liter, whereas in normal saline it is 154 milliequivalents per liter. So it is very high than our bodily value, but it is still called normal saline. Okay. So normal saline is used. Ringer's lactate can also be used. Ringer's lactate is more physiological than normal saline because it has 130 milliequivalents of sodium. It has I think 100 milliequivalents of chloride, 4 milliequivalents of potassium, 1.5 milliequivalents of calcium, and 28 milliequivalents of lactate. Okay. So normal saline contained only sodium and chloride, whereas oral contains sodium, chloride, potassium, calcium and lactate. Remember, this lactate is not an acid. This lactate, when the liver is normal, it gets converted in our body to bicarbonate. So it is actually a basic solution. So oral is basically a basic solution or an alkaline solution. Please remember that. On the contrary, NS is an acidic solution. Okay, we'll erase this also. So oral and NS are the two commonest fluids used. Obviously, we cannot use dextrose containing fluids because sugars are already high. So 5% dextrose, DNS, they cannot be used. So NS and oral are the commonest solutions used for fluid management DKA. So first option is a correct option. It is used. 3% saline. 3% saline is actually 3 times. I think it contains around 560 milliequivalents per liter of sodium. It is not the initial fluid choice. Okay, in the last question we discussed 3% saline is used only in case of severe hyponatremia. In this case, sodium is only 128. It is just a mild to moderate hyponatremia which does not need 3% saline. Also, we have something called pseudo hyponatremia. Before labeling someone as hyponatremia, we have to rule out pseudo hyponatremia. When sugar is high, it dilutes the blood, so sodium will be falsely low. Similarly, before diagnosing hyperkalemia, we have to rule out pseudo hyperkalemia, because when lab sample is kept for a longer time, it lyses and all the potassium within the cell comes out. So before diagnosing electrolyte imbalance, we always have to rule out the pseudo condition, pseudo hyponatremia and pseudo hyperkalemia. So this could very well be a pseudo hyponatremia. Even if it is a hyponatremia, it is not severe, so it does not need 3% saline. So this is not used. So the question is, which is not used in initial management? So this seems to be a correct answer, but we'll read the other options also. Intravenous insulin, obviously it is used. We discussed it is the third step in management, and potassium monitoring, it is the second step in management. So fluids, either oral or NS initially, then potassium supplementation and monitoring, and insulin and glucose control. 3% saline is not used, hence it is the answer in this case.